Over to you, ma'am.
So the topic is intrapartum acute bradycardia. I'm just going to present 3 clinical scenarios. First one, a primary induction of labor at 40 weeks on oxytocin drip, prolonged deceleration due to uterine hyperactivity. Oxytocin was stopped and the fetal heart returned to normal. Subsequently, patient had a vaginal delivery of a healthy baby. The next situation is of a 32-year-old gravida 4, para 3, living 3. First one was a normal delivery. Second one was a cesarean section for breech. And the third one was a VBAC. Nice healthy babies. The present pregnancy, she was term, she went into labor, spontaneous labor. And then this is the kind of a picture that you get to see after this point, prolonged deceleration. So an emergency cesarean section was done within 18 minutes. Uterus was found ruptured. Baby was partly in the abdominal cavity. The Apgar was 1 and 8 at 1 and 5 minutes. The third case is of a primary with previous myomectomy for multiple fibroids, term, in labor, sudden acute pain, cesarean delivery 32 minutes later, ruptured uterus, deeply asphyxiated baby found to have HIE, subsequently developed cerebral palsy. So in the outcome of these 3 cases, one is healthy baby, another one is a asphyxiated baby but resuscitated and healthy subsequently, and then the third one was resuscitated but subsequently had cerebral palsy. So essentially, when I say fetal bradycardia, acute fetal bradycardia is a heart rate less than 100 beats per minute, and if it is for more than 5 minutes, it's a prolonged bradycardia. But this is a terminal event. The fetal bradycardia that is normal, that is okay, that you get to see in the antenatal period is associated with SLE, where there is a AV block. But there, the baseline variability remains. Acute prolonged decelerations is the correct terminology here because we want to pick it up before there is bradycardia. This is a sudden, abrupt decrease in the fetal heart rate of at least 15 beats per minute, and this should be persisting for longer than 3 minutes. So what is the significance of this? This is a manifestation of acute fetal hypoxia and therefore is an obstetric emergency. Now you can see here, the variability is good, everything is fine. Suddenly there is a deceleration to almost 60 beats per minute, and this is lasting for about 3 minutes, and then subsequently it continues to be there and is called as a bradycardia. Now, hypoxia in the intrauterine period, especially in labor, is a very common event. It is inevitable during contractions. In response to this hypoxia, the heart rate reduces. And this is a cardioprotective reflex because when the heart rate reduces, the workload is also reduced. Now you will see that in spite of repetitive intermittent decelerations that we get to see during labor, the heart rate almost always returns to normal, and when these babies are followed up, there is no neurologic damage at 3 to 9 months. So this is the little bit of decelerations that we get to see in labor. As against this, the long-term hypoxia that we get to see in fetal growth restriction, etc., there is a compensatory mechanism there, which is brainstem sparing. The fetus is able to remodulate the cerebral blood flow, and it preserves the blood areas to the most important parts of the brain, which is the brainstem and the basal ganglia. This is at the expense of those areas that regulate non-essential activities, that is the cerebral cortex. So cerebral cortex gets less blood as against to the brainstem. So what happens in this acute prolonged deceleration is an acute, profound, sustained hypoxia. There is anaerobic metabolism in the myocardium. There is accumulation of lactic acid. This causes myocardial depression. This causes a reduced force of contraction. The heart is not able to contract as well as what was before, and therefore there is reduced perfusion to the fetal brain, and this causes hypoxic ischemic encephalopathy. What I am trying to stress here is the brain and the heart doesn't have enough time to put up a compensatory mechanism wherein it can pump good blood to the basal ganglia, whereas because it is sudden and profound, it is taken unawares, and therefore there is injury to the most important part of the brain. So this is the prolonged, profound deceleration that you get to see, and this kind of total asphyxia causes damage to the brainstem and the thalamus, and this gives rise to what we call as the athetoid or dyskinetic cerebral palsy. Now, what causes this acute, prolonged deceleration? This could be due to causes which are reversible, that means you can put them back to normal fetal heart rate, or it could be due to irreversible causes. Now, irreversible causes of acute bradycardia, you all are aware, are placental abruption, umbilical cord prolapse, uterine rupture, acute fetometal hemorrhage, a rupture of a vasa previa, end-stage chorioamnionitis, that is FIRS, inflammatory cytokines can affect the myocardium, and therefore I've had one patient, a very VVIP doctor's family. She came with fever, and then the next couple of hours she developed a little deceleration. We took her immediately to the theater, but it was a nice 3.5 kg fresh stillborn baby at section. So this can happen. So rupture of a uterine artery, pseudoaneurysm are much rarer causes. Reversible causes of acute bradycardia include uterine hyperstimulation that happens when you either give misoprostol or oxytocin drip, maternal hypotension due to supine position, or it could be due to the epidural analgesia that we give in labor. It could be due to sustained umbilical cord compression due to maternal position. The position is affecting the cord and it is causing compression. Maternal hypothermia also can give rise to acute bradycardia, maternal hypoglycemia, and when you take a long time to do external cephalic version in a woman who has got low BMI, etc., these also can cause reversible acute prolonged deceleration. So now, having said that, how are we going to manage? First thing, relevant medical history, and then you look at the metal vital signs, the pulse, the BP, to find out if she is going through any hypotension. You do an abdominal examination to find out about the contractions, and a vaginal examination to rule out cord prolapse, APH, etc. And so therefore you are ruling out reversible from irreversible causes. One thing that we must remember is that hypoxia and acidosis may develop faster in patients with thick scanty meconium. That means a fetus which is already distressed during antenatal period can quickly go in for prolonged deceleration because of their pre-status. Now, correction of the reversible causes, you all know. And when there is supine hypertension, that you can do is to change the maternal position, umbilical cord compression or supine hypertension. Then if she is on a oxytocin drip or if she is on a misoprostol, remove the uterotonic agent, and if the contractions are not settling, then best is to give a relaxation to the uterus. Rapid infusion of intravenous fluids to restore maternal blood volume. This follows epidural analgesia. So you give a lot of fluids and quickly and restore the blood volume. Now there is something called as 3, 6, 9, 12, 15 rule. This most postgraduates will be aware of. This is a recommendation based on the observational data, and in the absence of intrapartum accidents, that is cord prolapse, APH, etc., it is found that 90% recover in 6 minutes, 95% recover within 9 minutes. It's only the 5% that go in for a terminal event. Now, in the first 3 minutes, what we need to do even before it reaches 3 minutes, once you find that there is prolonged deceleration, call for help, get an anesthetist very quickly and a neonatologist who's able to resuscitate the baby, get a supporting staff, clinical examination to exclude irreversible causes and correct potentially reversible causes, give her fluids fast if she's hypertensive, etc., etc. In the next 3 minutes, that is at 6 minutes, you need to continue intrauterine resuscitation. 90% prolonged decelerations return to normal in this kind of situation. And the next 9 minutes, when it is 9 minutes and the deceleration is continuing, shifted to the OT, even there, it can return to normal because 95% of them return to normal. It can happen in the OT. Now, at 12 minutes, reassess the fetal heart rate to make sure it is recovered. If it has recovered, fine, you can shift her back from OT. If it is not recovered, even then urgent birth is required. You need to administer anesthesia. At 15 minutes, commence emergency operative delivery. If she is close to delivering vaginally, if she is fully dilated and close to delivering, you can do an instrumental delivery. If you feel that is not possible, you will have to do an emergency cesarean delivery. Now, many people are not aware of the drugs that are available to abolish excessive uterine contractions. Terbutaline 250 micrograms subcutaneous is not available. Ritodrin is available in some places. It's called Ritrod, contains 50 milligram in 5 ml. You give about 0.6 ml in 10 ml of normal saline slowly. What is atosiban can be given, but you see the onset of action of atosiban is 10 to 12 minutes. Too late for us to do anything about this kind of prolonged deceleration. Nitroglycerin is a good choice. 50 to 100 micrograms IV as a slow bolus repeated every 2 minutes to a maximum of 400 micrograms. Now, nitroglycerin comes as a 5 ml ampule and it contains 25 milligram per ml. So, 25 milligram in 5 ml. So, that means 5 milligram per ml. You take 1 ml of nitroglycerin, dilute it in 99 ml of saline. So, that makes it 5,000 micrograms in 100 ml. So, you give 1 ml of this solution slow intravenously. I will repeat, nitroglycerin, take 1 ml, dilute it in 99 ml saline and give 1 ml of this slowly intravenously. So, this is to abolish tetanic uterine contractions that can sometimes give rise to prolonged deceleration. Now, there are certain fetal heart rate patterns that predict poor perinatal outcomes. Reduced baseline fetal heart rate variability before the onset of prolonged deceleration. See, even before the onset, if the variability is reduced, or within the first 3 minutes of prolonged deceleration, if the variability is reduced, it indicates a poor prognosis. The depth of the prolonged deceleration, the deeper the trough, the greater the chances of bad fetal outcome. The duration of ongoing prolonged deceleration, supposing it's 15 minutes, 18 minutes, you've still not delivered the baby, then that also can give rise to a very poor outcome. See, this is the decelerations, baseline variability before the prolonged deceleration has set in. You will see that the baseline variability is fairly okay here. And this indicates that the fetal reserve is good. So, this fetus is able to withstand the hypoxia that comes with the prolonged deceleration. Here again, in the first 3 minutes of prolonged deceleration, you will find that the baseline variability is fairly okay. So, this baby also can have a good outcome. And against this, you look at this particular trace, you will see that even before the onset of prolonged deceleration, the baseline variability is very poor, and subsequently in the first 3 minutes also, the baseline variability is poor. This indicates a poor outcome. Now, depth of prolonged deceleration, the greater the decrease in the fetal heart rate below the normal baseline, greater is the loss of fetal cardiac output. That means hypotension, and therefore the pH goes down faster. So, to summarize, the management of prolonged decelerations in acute bradycardia, immediately assess the vital signs, do an abdominal and vaginal examination, find out what could be the cause, reversible causes, immediately do attend to whatever is required. If she's getting too many contractions, stop the drip, give her tocolytic, and infuse fluids if there is metal hypotension. If there are irreversible causes, it is very obvious that you will have to deliver the baby immediately. Now, cord blood ABG was mentioned by my previous speaker also. This is very important. This is the most objective determinant of the fetal status. Metabolic acidosis can be made out, at birth can be made out, and therefore, medico-legally, this is extremely important. If normal CBG and there is no acidosis, that means, you've got a cord blood sample which is okay, then it is a savior to you, because tomorrow, even if the baby has any problem, 3 months later, 6 months later, 5 years later, you are safe because you can prove that there was no acidosis at birth. This is also more importantly a prerequisite. Supposing the baby is very hypoxic at birth, based on the pH and the base deficit, this will need a therapeutic hypothermia. So after delivery, time documentation of events is important. Across the time, you need to document the events. This is extremely important in these kind of cases, which may go to court not now, not 3 months later, not 6 months later, 3 years, 4 years later. So it is better to document everything now. Debriefing, that means telling the couple, telling the family about it, and documenting that you have told them all these details, because they can be a potential medico-legal case. Today they are all nice. Doctor, you tried everything, you did everything, but tomorrow somebody might instigate them and they might go to court. Follow-up of the neonate is very important. Don't stop after discharge. Follow up the baby, even if the baby is not under your care. Follow-up of the neonate is very important, and save all records. So to conclude, involve all staff in the labor room, because this is an obstetric emergency. You might be used to shoulder dystocia drills and various other drills. You need to have a drill for prolonged deceleration as well. What to do in the face of prolonged deceleration? Awareness about the possibilities of prolonged deceleration. Recognize the problem so that they are able to pick up. You may not be around the patient when it happens, so the staff should be able to pick it up. Drills to put into swift action when it takes place. Documentation and follow-up of both the mother and the neonate. Thank you very much for your patience and attention.